most of the attendees today are post MBBS looking forward to building their careers. So I probably start at the same level. So I finished my MBBS in 2001 and wasn't sure about, actually, I was sure I wanted to do general surgery. I wanted to be a surgeon. And with the way things rolled, I ended up in the United Kingdom. So I gave my PLAB and went there to do general surgery, which is where I did my MRCS and my initial training. But I was not aware of this specialty when I entered that country. I happened to do my first work, or they call it a post. So my first 6 months post was in emergency medicine. At that stage, it was called accident and emergency. Interestingly enough, we are at a similar phase in India where people are now recognizing it. Over there as well, it had just moved from casualty to accident and emergency, and the specialty was finding its sort of identity. So a lot of people working in that department, like in India now, were not really trained emergency physician, if we can call it that way. So I was lucky I started with that post and I really enjoyed it. I think primarily because it was a bit of everything. It was a lot of adrenaline rush. It was a lot of doing all kinds of things. Every day was different, and pretty much that is the main reason I'm still in this specialty and probably do it all my life. Is that whole whether we call it adrenaline or whether we call it unknown, or whether more importantly it's an opportunity every day, more than one, where you get a chance to help someone where they are panicking, where they are unsure, where they are not quite, something suddenly has happened to them, or so they believe, whether it is chest pain, abdo pain, whether they've collapsed, they've had a syncope, and so on. So it's the only specialty now other than the general practitioner, which sees anything and everything from a newborn to the last day of life, whether it is fever, whether it's trauma, whether it's any illness whatsoever. So I was exposed to that in my first post. And plus, another very important feature about this specialty, which I loved, was independence. What I mean by that is, as a doctor working in the emergency department, you are able to treat and start managing on your own. You're not dependent on, like, for example, if I was trying to be a surgeon, then you're dependent on the anesthetist, you're dependent on the OT technicians, you're dependent on a lot of other factors before you can actually get on and do your work, which is whether it is taking a gallbladder out or fixing somebody's femur. You're actually dependent on a lot of people. Similarly, whether with other specialties, it is that kind of dependence, which is not there in the emergency. Basically, people walk in, you start assessing them, you start treating them, you start managing them. Obviously, you're going to need the help of the specialist, and you would, get them involved as and when required, depending on it. Plus, it's completely unselected. So you don't know what is wrong with the patient, as opposed to when you're working in a specialty, they tend to already have a diagnosis or have a particular ailment for which they're coming to you. So there is that where you need to actually put the jigsaw together. So a combination of this is what I found in my first post. But like I said, I had gone there to do general surgery. So I did my MRCS, I did my surgical rotation. And at that stage, I realized that I'm enjoying emergency a lot more than I'm enjoying the operation theater. So then I moved firmly into emergency medicine and did the higher specialist training over there, through which you rotate through pediatrics, orthopedics, intensive care, anesthesia, and you pick up all those skills, and then you come back to the ED and consolidate all that knowledge through the rotation over there. So obviously it's a bit different to India, where all this is in 3 years. Over there it is 2 + 4, 6 years. And then I worked as a consultant there, but always wanting to come back to India, wanting to come back home. So 2015 is when I came back to where I was from, Bombay. And I've been here since. I've been with Apollo since it started about 7 years ago. And again, I got lucky because emergency medicine is new in India. It's getting established. Apollo as a brand has done a lot and continues to do, getting EM well established. So it just started in Mumbai, and join it, and we've got our own training programs, including DNB, including the Medversity program and the Royal College of Emergency Medicine. So yeah, that's where I am.
Thank you, doctor. So, as we were talking about how emergency specialists can have array of clinical areas of all age groups, and I'm sure there should be some particular traits or personality required for this specialization. What do you think about that, doctor?
Yes, absolutely. So I think most define this is what I enjoy, this is what I don't enjoy. Some specialties become quite psychiatry and general practice. Definitely a huge influence about who you have worked with. So you see certain personalities in certain specialties and you get influenced by them and you start enjoying that specialty because of those people that you've interacted with. So there are all these factors, and it is, I think, not that stressed upon in India particularly, but I think it would be a good time when you're finishing or when you're doing your internship to focus on what specialties you're actually enjoying, because that's what you're going to be doing rest of your life once you become a specialist in that field. So, actually thinking about the day-to-day or the long term, so we've got, like, I've got a lot of surgical friends now, and as age comes on, they feel that major surgeries and other things may not be something they want to do, and so on. So coming to emergency medicine as a specialty, I think you just need to be very adaptable. You need to be, you can't have a routine. So if you're someone who likes a routine, if you're someone who likes, okay, I'll go at this time, I'll do this, or I'll have a 3-hour OPD and whatever. So you can't have a routine because you really don't know what you're going in for, what time you'll finish, what will be the kind of stuff you're doing. So you should be very adaptable. You should be wanting to do anything and everything depending on what that day brings out. A lot of teaching and training are core of emergency medicine. So you should have some inclination towards that, where you're teaching, training, helping doctors, nurses, paramedics, allied health professionals. Plus, one thing I've noticed over the years is that some doctors are very uncomfortable if they don't know the outcome, as in the diagnosis or the follow-up. So again, that's not emergency medicine, because we don't always know the diagnosis. We are in the business of stabilizing, resuscitating, making sure they make the way through the hospital into the intensive care or operation theater or the ward, and then the specialists take over. So yes, you can follow up on them, but you don't automatically get to see. A lot of the times you'll be sending off some basic labs, doing some management, and then they're off. And, so we do not, that diagnosis and follow-up is not a strength. Resuscitation is, making a difference about saving someone's life is. So, if you're looking for that kind of adrenaline rush, then this is the specialty for that. And like I said, adaptable, and in all forms, not just clinically. Clinically is the most important because they're unselected patients. You have to have a completely open mind with each patient, and you need to try and find out what is wrong with them. Similarly, outside the clinical side, administratively, politically, financially, and all the other elements that are part of at least the Indian system. There are, again, in the UK, there were different challenges in the same way. So you need to be able to deal with that, the same answer may not be on for the same problem on 2 days. There may be different answers. So you should be someone who can think outside the box, think on your feet, and be able to come up with solutions which may not always be written in the textbook, or they may not always be taught to you in a classroom. So overall personality, adaptable, thinking on the feet, adrenaline rush, that could be the kind of people that would enjoy emergency medicine.
When we talk about golden hour, I know how stressful it can be for a specialist as well as the patient. So what do you think the procedures a specialist should be well versed with?
So the golden hour concept, basically all doctors need to be aware of it, and then depending on where they're working and what kind of system, how big the hospital is, it would make a difference. Obviously, it makes a difference at home. You don't know you're walking somewhere and you have someone collapse on you. So there are a lot of these absolute basic procedures that may make a difference. And this is where the 1-year program in emergency medicine, which is available, where you can actually work, which will do both things. One is you to pick up all the basic resuscitation skills, whether it's chest compressions, intubations, defibrillation, is not so much into arterial line, central line, but you start getting some exposure to that, along with pacing, splinting somebody's fractures, resuscitating them with blood, and so on. So all these procedures are something you pick up, plus you realize in that 1 year whether you're actually, this is a specialty for you or not. So you don't lose anything because you picked up all these skills and you're well aware, and your confidence goes up because you've been able to do all these things. And also it tells you that, this is what emergency medicine is and whether you're cut out for it or not.
Absolutely, doctor. So we have a lot of questions from our attendees. So should I start taking the questions from the attendees, doctor?
Sure.
So Dr. Priyanka would like to know the scope of emergency medicine specialist in government hospitals.
So government hospitals, 2009 is when EM got recognized as a separate specialty, and it's part of the NEET, as you would all know. Both MD and DNB programs are being run in the country since then, around 2010-11. So from government hospitals, in fact, this year, the ruling came last year that every medical college should have a fully functional emergency department. Clearly, we are far from it because we don't have enough emergency specialists, we don't have enough seats, and so on. So definitely there is a huge prospect because it is getting more and more recognized. And just like the private setup now, for many years has dedicated emergency departments with teams, with good prospects, the government hospital are going to have the same thing. They already have in some areas, but not enough. But over the next 10-15 years, I'm sure that is going to go up in a big way. So people who are actually formally trained doing the MD emergency medicine would have a huge role, will have a huge prospect in developing departments. And then they will be almost the initial people who would set up the training programs and have the departments function in a organized fashion as opposed to being a casualty.
So Dr. Vivek has done his MRCEM, and he wanted to continue in Maharashtra as career in emergency medicine. Anything DNB or MD needs now?
Sorry, you got cut off a bit. He's done MRChem and then?
And he wants to continue his practice in Maharashtra as a career in emergency medicine. So anything DNB or MD, what he can do?
So yeah, that is one of the unfortunate things that has happened. Till a few years ago, MRChem was recognized as the postgraduate qualification, and you would get an additional qualification. So that is no longer valid. So unfortunately, that is a bit of a roadblock. MD or DNB are equally good, but both are through NEET. So you would have to apply through NEET and complete the 3-year program over there. And then you would get one of those degrees which are MCI recognized, and you would go on the additional qualification.
So Dr. Krishna here has completed his emergency medicine and he wants to run his own clinic. So is it better to go for our own clinic or in a corporate hospital setup?
I think it comes down a bit on your personal choice. I would never run a clinic, but that's probably why I did medicine in UK as well. And I did some clinics and they're just not made for me. I can't sit in a room and people come in and I prescribe some medicines and they go out. So it's definitely not for me. Definitely as an MD emergency medicine or a specialist in emergency medicine, you can hold clinics, but the word emergency means 24/7. Right. So pretty much for me, that means it's an emergency department, whether you are working in it at whatever level, it's a team game. You have a team of people working over there. So you could definitely have an outreach clinic definitely you could have a clinic which is following up the patients that have come to your ED. So for example, you've done some stitches or you've done some burn dressing or something like, or you've given them some antibiotics for an infection and they come back to your OPD. Certainly you can have a setup like that. You can certainly run your own clinic just like a MT internal medicine. So like a internal medicine clinic can be run by emergency physicians as well. But that is if that is what you want to practice, then certainly it can be done. But for me, emergency means 24/7. So it usually means a department.
And Dr. Anwar here, how can I move into emergency medicine from internal medicine?
So if you have, um, emergency medicine, anybody who's done an MD in internal medicine or an MS general surgery or an MD anesthesia, any of these specialties can, if they find emergency medicine exciting, if they find it as their career, they just need to find a department which is working as an emergency department as opposed to working as a casualty. That's not a criticism. I'm just saying that, different departments are at different stages of their evolution. So if you're looking to work as an emergency physician, you need to identify in your area or wherever you want to work, which is a good emergency department where they can actually perform as an emergency physician. So for MD emergency medicine, it is quite easy to just join a department and work there.
So Dr. Mohammed here would like to know how to practice as an emergency physician in remote areas with lack of resources.
Yeah, that is a huge challenge. Emergency medicine itself is a challenge. Remote areas, again, if you have the right personality for it, there's nothing like it. Find ways and means of sorting that out. Screen at frozen. All okay?
Yes, doctor.
So in the remote areas, you would obviously set up a different kind of a department. I have the luxury of working in a full metro with a full-fledged quaternary care center. So my emergency department caters to anything and everything under the sun. Whereas in the remote areas, you would have to be careful in designing, setting up the process and the systems about whatever you can cater for.
Sir, you're not audible.
Amount of effort to develop a network where you would transfer the patient that you can't do difference, because you could be the one stabilizing the right, you could be the one thrombolizing them, and then ejection. Hello?
Yes, doctor. Now you're audible. Yes.
Okay. So we were talking about the remote setup. So I was saying that actually there's a more potential over there to actually make much more difference to the population that presents to you in emergency, but you just need to set up your department in a way where you're able to stabilize, you're able to keep whatever resources and be very clear on what you can and you can't do. And in the same way, develop a network where you'll be able to transfer these patients safely. So having a good sort of ambulance setup or a good transfer setup where the patient requires, and you liaising with that particular meters, whatever. So you have that, and you have your staff ongoing training, and you yourself are being trained in that kind of care. So definitely, in fact, you will be doing a lot more good work by working in the remote center. Just have to design it appropriately.
Dr. Amu here would like to know, is MEM course same as MD emergency medicine?
The curriculum is very similar. Both are 3-year programs which train you in emergency medicine, and obviously it will cover similar kind of things. The difference between the two is one is recognized and one is not recognized by the Medical Council of India. Now it is called NMC. So again, the challenge comes at that level where, when you go to particular organizations, they may or may not recognize your degree. Most people that are aware of emergency medicine would probably treat them similarly because they know that you've done a 3-year program and you've been trained in that specialty, which means you're able to look after the child who's just born or the elderly trauma. Medicine, it doesn't make a lot of difference, but yes, on recognized. And yeah, that's about it.
So we have few questions that is related to fellowship programs. They would like to know how it can be useful and why they should do these kind of fellowship programs.
So yeah, I mean, the gold standard or the ideal thing for anybody pursuing a career in emergency medicine has to be NEET, has to be getting into an MD or a DNB emergency medicine. There's no discussion on that. That is the gold standard. We know how competitive that exam is. We know how less often that comes around. So when you do not have access to that, when you're not able to get to that for whatever reason, or you choose not to do it, then all these other programs come into the view, whether it's MEM, whether it's a fellowship, whether it's the MRCEM, which is affiliated to the UK Royal College. So any of these programs will give you the training, the curriculum, and the structure for you to develop yourself as an emergency physician. So that is how I would look at it. Again, I'm not totally happy about it, though I've been abroad. It is another way of getting out of the country. So MRCEM is a recognized qualification within the UK. It is a recognized qualification in other parts of the world as well. So definitely doing an MRCEM opens doors for you. It gets you what we call as MMC or a GMC registration, license to practice from the government. The MRCEM gives you the same in the UK. So it opens up doors for opportunities over there. So MRCEM has that advantage over the other memberships and fellowships, but they all are in the same bracket. They're not recognized. That could be, depending on you, it could be an issue. According to me, it doesn't make a lot of difference. But again, I'll just repeat, gold standard is NEET and getting an MD or a DNB. Then you've got an additional qualification from your local medical council.
So the same note, Dr. Rohit would like to know that how can you pursue for MRCEM in India and then FRCEM in UK?
Okay, so MRCEM it's an exam which is conducted by the Royal College. It has got 3 different parts. All the 3 parts are conducted in India. There's an application process and you give the exam. Ideally, you should be in a department where you're learning that, but you could be in any department and give this exam. So there is no restriction of any kind. You just have to be MBBS from a college which is recognized by the Royal College, which is basically a WHO recognized medical college. With most parts, the passing rate is around 30-35% for each part. So they're not easy. The first part is basic sciences, second is clinical, and third is a OSCE, so objective structured clinical examination. So MRCEM can be given in India over a period of 1 or 2 years from any center, from any part of the country. And once you've done that, you are after, I think it is 12 months or maybe 24 months, you're eligible for the FRCEM, which also now has been started in India. At least of the FRCEM, you would have to go to UK and give it. There are already emergency doctors from India that have passed the FRCEM and have got that qualification under their belt. So it's very much doable over here. Again, I have to repeat, they're not neither of them are recognized to get your additional qualification.
So, sir, on the same note, Dr. Neha would like to know the opportunities for emergency medicine in various countries, maybe in abroad.
Yeah, so I mean, it's by design, it's a very hard specialty. You're working odd hours. Most of the times, the department is the busiest when the clinic is shut. So evenings, public holidays, weekends. So automatically, when you're in this specialty and working in this type of department, you'll be working more on holidays, more on evenings, more things like that. So because of which it's not a very popular specialty in the developed world, which is why there's lots of demand and a lot of opportunities in the UK. Similarly, in the US, Australia, a lot of countries there is a demand for it. Getting into these countries, each countries have their own set. Like I said, the MRCAM opens up the door directly into the UK, and once you've got it, you'll be directly eligible, and most likely you would get a job over there, and you can start working over there, and then pursue FRCEM and so on. The MRCAM again gives you a better job prospect in the Middle East directly. So once you've got a specialist and they have their own career structure, which you can fit into with the help of that qualification. For the Australia, you would have to give a different exam after MRCAM as well. US doesn't recognize any qualification anywhere. So you'd have to go through the standard USMLE matching and so on to get into that. So yeah, that would be the countries that I know of.
Okay, doctor. So as you were talking about the odd hours working and, even on holidays, we have to be there on the department. So Dr. Sheher would like to know, is emergency medicine is extremely stressful branch?
Yeah, so I think stress comes with basically it's like enjoying, right? So if you enjoy what you're doing, then you have less stress.
Right.
So which is where choosing the right choosing the right specialty, and then also working in the right department. So your team, everything plays into it. So by itself, yes, emergency medicine is definitely more stressful than, I'm sorry if you get upset, but dermatology or psychiatry or something like that. It might definitely be more stressful than that. But at the end of the day, if you're enjoying it, for me, dermatology will be more stressful because I just want to enjoy it. So it's like that. Definitely, it's more stressful. But if you've got the right team around you, if you picked up the right skills and you enjoy what you're doing on a day-to-day basis, then I don't think it is. And plus, you need to keep sort of with any specialty, you need to keep upgrading your skills, staying up with the demand. And again, as a team, if for example, in the UK, once consultants reach the age 50, then they would come off the on-call rota. They would not do certain shifts and things like that. So there'll have to be those kind of, you need to be in that kind of an environment where, the team looks after each other as well. If you're not, then yeah, it is definitely more stressful.
It's all according to their own comfort and the liking towards the department. So Dr. Raji would like
some
to
element of
so best possible investigation process during the patient enters first in the department. The procedures which you would like to say. I mean, I'm sure it depends on what kind of patient is coming inside the department.
Yeah, I'm not sure what that, I mean, that's a clinical question or?
You would like to know what kind of procedure emergency medicine specialist should be well versed with. Maybe that question what we already spoke about, but Dr. Sarthak would like to know more about it.
Yeah, so I think, you would have to have the resuscitation skills, whether it's a neonate, whether it's a pediatric, whether it's an adult, or whether it's a trauma. So it obviously intubation across different ages with or without trauma, those will be the core skills that you need to have. Resuscitation in the form of defibrillation, pacing, from a cardiac point of view. So you would have to have those skills from procedures point of view, putting in invasive lines like arterial lines, central lines, as well as intercostal drains. Surgery, orthopedic wise, dislocation, so relocation of various joints, putting on plasters, debriding wounds, those would be there. From anesthesia point of view, rapid sequence induction, are now called drug assisted intubation, as well as sedation. So procedural sedation for children as well as adults. Yeah, I think, and suturing, basic different
Right.
types of suturing. These would be all the procedures that you would need to be well versed with. But obviously, you won't have that at the start. Over a period of your 2-3 years experience, you pick them up as you go along.
Dr. Gokul here would like to know, in upcoming years, is MRChem necessary or is it okay to survive with emergency medicine physician?
Again, the answer will tail back to whether you're an MD or a DNB. So if you're an MD or a DNB, it probably MRChem doesn't add much, in that way. But if you do not have the MD or a DNB, then definitely MRChem, being an internationally recognized qualification, holds some weightage. So wherever you're going for an interview for a new job, or you're performing, or you're in your own organization, in your own hospital, you're trying to develop something, or you become an instructor for ACLS, ATLS, PALS, and so on. Having an MRChem under your belt would definitely be a huge positive. But if you're having MD or a DNB, it probably doesn't have much value unless you're looking to leave the country.
Absolutely, doctor. So Dr. Harsh Kumar would like to know, what is better for future of individual, is EMD or IDCCM?
I'm actually not very sure. IDCCM, I'm not very sure whether that is recognized. But more importantly, there are two different specialties. So the first thing we need to understand, for a long time, emergency and critical care are treated as one. Most of the hospitals would have critical care specialists looking after the emergency, which is why that area is blurred. But as an individual, you need to decide whether you are an emergency physician or an intensive care physician, because they are two different specialties, and that would probably answer whether it's EMD or IDCCM. IDCCM by design don't see children. They don't see trauma that much. They are seeing a lot of critically ill adults, whether it's sepsis, pulmonary, cardiac, and so on. Whereas in an emergency physician, like I said, you're seeing everything. You're seeing the most trivial of cuts. You're seeing the most trivial of viral fevers, as well as you're seeing the sepsis, where you need to resuscitate them, get lines in, and start the sepsis bundle. So, you're doing a whole spectrum, as opposed to critical care medicine, where you're actually working on them. We're working on the patients on days together to get them back home. So there are two different specialties, and depending on what floats your boat, you need to pick that one.
Absolutely, doctor. So, doctor, when we talk about, emergency medicine and everything, I would like to know, what were your challenges on the initial stage when you started in this particular department?
I think the challenges were that you actually need to know, if you like to call golden hour, or the first hour of every specialty. So I definitely found children a lot more challenging initially. Just getting history out of them or treating them was challenging. So again, in the UK, there was a huge number of footfalls from psychiatric illnesses. So psychiatry again was a challenge about how to assess them, how to manage them. So pediatric psychiatry. Then there were systemic challenges. Like, for example, it's a government setup over there, so getting admission beds and which you might find strange listening today, is getting the specialist to see the patient. Whereas in India is the opposite, because we work in the private, there are 4 cardiologists available for one chest pain. There, they wouldn't even come down for a bradycardic patient who's peri-arrest. So there were systemic challenges because it was a government setup, it was a different way. So there were those challenges. Yeah, I think pretty much those were the.
Any takeaways you would like to give it to our attendees here today?
Yeah, I mean, I think it's a great specialty. I think it's a specialty which, like I said at the start, it gives you opportunities every day, which you don't get in other specialties where you can make a difference. It might not be life-saving, but it still be a huge difference to that person's life because you've communicated to them well, you've explained to them what the condition is, what their options are, and how they can go about it. That reassurance, I think that is not there in many, means other specialties don't always have that opportunity. We have it on a daily basis, reassuring patients, which can make a difference in addition to saving lives from time to time. It's a completely team department, so you're never alone. You're not working on your own. You've always got somebody, doctors, nurses, paramedics with you, and you can bounce off them. So you're never, if you're not 100% physically or you're not feeling well for other reasons, you've always got some company. They understand each other, and there's a lot of fun that you work as a team, which you do not have, I think, in other specialties. You can be quite isolated if you work in certain specialties. Yeah, and it is not for everyone. So yeah, I think you need to have the basic skills. So it's always good to have that. But yeah, you need to know that you enjoy that, unselected spectrum of patients, and you don't know what your day is going to be like. Then that's all I have to say.
Okay, doctor. So Dr. Hari Krishna would like to know, how is the scope of MBBS graduate student in future who completes his or her fellowship training in emergency medicine in India, as in perspective of cracking a job, growth in emergency medicine department, or should we do any other further additional courses?
Sure. So fellowship in emergency medicine, this is now, unfortunately, it is not a consistent meaning to that term because there are different organizations, different meanings to the fellowship. Definitely, from a job point of view, when you're going to, a private setup in particularly, you would have some advantage of getting a job working in that emergency department or working in intensive care for that matter, as well as working in other parts of the hospital, because they would know that you've got some emergency skills because you've completed that program. So job prospect wise, definitely I feel there is a good chance you'll get a good job. From a growth point of view, it comes down to you as an individual. You need to keep progressing. So I would definitely recommend doing the MRChem because it's a more recognized, more, you can say, identified as a qualification. So MRChem would help whatever fellowship you have done to consolidate that with an MRChem or a European diploma. There are other exams similar to that in emergency medicine. And then growth would depend on how you grow yourself as an individual. Like I hinted a bit earlier on the political, financial, administrative, emotional, and other psychosocial aspects, you develop yourself that way. So there are a lot of emergency doctors who do some medical legal training, or they do some administrative training like an MBA and things like that. You would, because you're exposed to emergency medicine and it's getting more and more recognized in the country, even the management is looking more at EM because they understand all specialties. So they know that you would be able to solve a lot of problems. Like, for example, a couple of years ago during COVID, the BCCI wanted Apollo to run the local, not local, but the national first-class cricket tournaments. And it was put upon the emergency department. So we would organize the bio bubble, we would organize the safety and managing that. So there are a lot of these other opportunities which will automatically come to the ED. So if you develop your skills administratively, financially, medical, legally, and so on, then there is no restriction to the growth. But obviously, if you stay as an emergency doctor without upping your skills, without getting more things under your belt, then that would be different. But once you're in the specialty, it will automatically happen to you as long as you're true to yourself.
Absolutely, doctor. So when we are talking about fellowship programs or any courses for a year, so I think it is more like a stepping stone towards understanding the course, getting more clearer vision about it, than what you can expect in next 3 years if you do a proper MD course. So I think it is more, it will make you more mentally strong if you want to do this particular course or you don't want to do this particular course. So I think that way it's a win-win situation if you do a fellowship program.
And it goes up and your confidence goes up. Because you will not get scared of a sick patient, which is natural. So you would be able to, you would have the tools which you will be able to look after a sick patient. You know what is to be done. I need to do this, this, this in this order. And that confidence also will come to you. And then whichever specialty you end up with, your confidence will be higher.
And you are getting the practical knowledge and everything. I think it's kind of a great thing. So Dr. Sheikh would like to know if FEM graduate can work in Gulf countries.
Yeah, so again, I think it will hold value over there because emergency medicine, that those countries recognize emergency medicine. So on its own, obviously during interview, it will help that you've done some training for 1 year in emergency medicine. And you'll be able to demonstrate that. And similarly, you will be able to tell them what are the procedures or what kind of patients you can look after. So definitely it will help. I don't have direct personal experience, so I won't be able to guarantee that. But I know that in the Middle East, emergency medicine, again, like I highlighted earlier, not a lot of people want to do emergency medicine because of its hours and things like that. So there's always demand. And once there's demand, if you have some qualification, it puts you in a better stead than the plain MBBS.
Any institutes which offer FRCEM in India?
FRCEM is not, most of them offer MRCAM or MEM, and FRCEM is a few years later, which you're usually doing after you've finished one of those programs. So there is no institute as such. Within Apollo, there are a few centers which FRCEM, the doctors working in the AD are giving the exam. Oh. And few have completed it.